I try always to create some sort of inviting, enticing title, and hopefully this one sucked you in a little bit. So I want to talk a little bit about what I'll call banana skins, the things you really want to avoid getting yourself into in any practice, whether you're in hospital or in general practice. Easy mistakes to avoid, etc. And a lot of the some of the examples we talk about rely on successful continuity of care. And so I was going to touch a little bit about on that, a bit about a background to it and the future of it. And as I said before, I really want to make it a discussion. So I will be sort of jumping into ask you questions if you haven't got questions yourself. Just it makes it flow better, and otherwise I start talking too much. But if you do want to butt in at all, please don't hesitate to jump in. And then I'm going to finish with a case study which I managed, or sort of managed, towards the tail end a couple of weeks ago. My final lecture I'm giving next week is about some tips for your exams, and it's termed "Horses Not Zebras." The zebras don't happen very often, but I had a case a couple of weeks ago which basically contradicted that whole title. We'll go through that later on. Aim to finish, about 10 to 1, 5 to 1, something like that. Okay, so now, sorry, it's only a very sort of rudimentary word form, but don't worry about the number of words. I just want to look at this case here. I'll give you time to have a look through it, about a minute or so, and then I'll go through it paragraph by paragraph. These two examples we're going to talk about, taken from the Medical Protection Society casebook series, which are available online, and they come out maybe 4 times a year. Are you familiar with those? Do you see those? Just nod if you do. No? If you're a member of the MPS, you'll get them sent to you usually. If not, they're available online in an archive form, and they're really well worth looking at. They can be sort of depressing, but in fact, you'll learn a lot from them, and you take a lot, and it does help you practice safer medicine. I mean, there are a lot of open goals clinically in here, which have not been managed very well at all, but it does remind us all to be as careful as we can. So just spend a minute or so looking through that one, and then there's another one to do, to have a look through too, and we'll just discuss the case. Okay, so I just want to add a disclaimer to these, and something we should recognise. We've got to accept the limitations of the information we're given to us by the MPS. We're not party to all the history, all the circumstances, all the past medical history of the patient. So we have to be a little bit careful how we judge these cases, but there are certainly some learning points within there. So in this case, you've got a 63-year-old man who visited Dr. C for his annual health checkup and routine bloods requested. Dr. A, another GP in the surgery, reviewed the results and noted that Mr. J had moderate renal impairment, of 59. Coded as having chronic kidney disease, Dr. A assumed Dr. C would follow his patient up, since he was the doctor who requested the initial blood tests. A week later, Dr. J was again seen by Dr. C. He had a sore finger after pruning some trees, blah, blah, blah. The results were not discussed and a repeat test was not mentioned, as Dr. C had assumed that Dr. A had seen the results and would have arranged subsequent follow-up. Things went, there's a bit of water under the bridge. 6 months later, Mr. J had an appointment with Dr. A regarding his painful osteoarthritis. Naproxen was prescribed and placed on repeat prescription. Previous results were overlooked, it appears, and a repeat renal function was not requested. Another year passed, Mr. J consulted, this time an episode of diarrhea and vomiting, and then a third doctor involved in his care saw the eGFR dropped to 50, and again, no further action was taken. Continued to receive naproxen on repeat for 2 years, and then finally, a locum doctor at the surgery, it's the 4th doctor who's seen this man, noticed a degree of renal impairment, stopped the naproxen, and as his eGFR at that point was 44. Subsequently, it returned to normal after the naproxen was discontinued. So I sort of put some bullet points at the bottom. So Ellie, what strikes you about that sort of the first couple of paragraphs there? Is anything jumping out at you? What are your thoughts on this? Can't hear you, Ellie.
Yeah, he was given the naproxen despite his kind of poor renal function. And I guess doesn't appear that the two doctors communicated the renal impairment very well.
Sure. So what we don't have in that first paragraph, we don't really know what his previous EGFR was like. It could have been hanging around 59 for ages. So we have to assume that maybe it was, I mean, he's only 63. It was probably higher than that. What would you have done if you were Dr. A, the second doctor, had done the blood test and found it to be 59? What would you have done in that situation?
So I'm not the usual doctor. Sorry, it's kind of confusing to follow.
No, you're not exactly. You're not the usual doctor, but you've done an EGFR. It's come back with an EGFR of 59.
So I'd want to check, like we said, the previous renal impairment, and I might send on our system. You can send a task, but like a follow-up, so that it brings the attention to his usual GP to follow that result up.
Yep, that's exactly what I would have done. Using the task feature, not a piece of paper, but actually a task. Again, in the corridor, bump into the GP, you could mention it, but they'll probably forget it, but it's a courtesy thing to do. The other thing you could do is set a recall, but the nurses hate recalls. So that's another option, is to set up a recall and even task them as well. And I'd probably set up a recall for probably, 6 weeks, something like that. And it's important to document your actions as well. In the first two paragraphs, this assumption comes up twice. They've each assumed the other person is doing what the other person is doing. And so it's important that to close off from your end, you summarize what you've done in writing, and also task the other doctor, and maybe set a recall. And what I would do is I'd task the doctor, and I'd probably copy and paste the wording I'd said in that task into the note, so it's quite clear in the train of communication. Miguel, what do you think about paragraph 3? Naproxen was prescribed and placed on repeat prescription.
Well, I feel like the fact that Dr. A kind of knows that there is a history of, or at least it was coded as a chronic kidney disease. Maybe the naproxen could have been, giving the script for naproxen was already questionable enough, but definitely the fact that it was on a repeat prescription probably should not have happened. I mean, just because the patient could have just kept taking more and more of that as well.
It's interesting. It was Dr. A, who was the second doctor. It wasn't the primary doctor, the secondary doctor who'd prescribed it and put it on repeat, and had apparently overlooked the look at the renal function. So he'd actually done the first blood test and not really done anything with it, and had actually continued to prescribe naproxen. So again, we don't know the circumstances, but yeah, you identified the correct point there. The naproxen, a non-steroidal, was placed on repeat prescription. As a general rule, I don't like to put NSAIDs on repeat prescription unless I know the patient well, unless I know they're going to come in regularly and they're not going to get lost to follow-up. Because this is a classic example. It can get overlooked, and if it's in blue, it's a long-term medication, or however it's coded, it can be repeated by anyone, and there's no prompt to look at the recalls or the bloods, which we should do. But certainly if someone's requesting a medication like an NSAID and it's not long-term, I would always have a look at the renal function, etc. Yep, that's right. And then finally, in the last two paragraphs, you get to the stage where there's two other doctors have been involved, and one of them, the sort of penny dropped, or maybe had a little bit more time, who knows, and worked out the problem. And luckily, the renal function was retrievable. Going forward, now that we've got to this point at the end here, and if you were Dr. A, say, Josh, if you were Dr. C, sorry, the usual doctor, how would you stop this happening again in the future? Or what safety nets would you put around this?
So there's been miscommunication. So, sorry, let me just catch up.
That's all right, no problem. Yes, there's been miscommunication. There's assumption on both sides. 4 doctors have been involved in this sort of situation over a couple of years. They've dodged a bullet in terms of dehydration and NSAID-induced nephropathy. What would you do in terms of stopping this happening again in the future?
I guess it's important that both parties, or all parties, understand that they need to document what they have and haven't done.
Yes.
So that if anyone needs to look at their patient file, they can see easily what sort of treatment's been started, what sort of blood tests have been done, that sort of thing, who's reviewed them.
It's quite good if it depends on the size of your practice, but you could have in your practice meetings or governance meetings, you could have a policy around making all non-steroidals non-long term. And you could ensure that somewhere clearly written in the notes there is an alert that is seen by everyone to say that this patient's got borderline renal function, and that just be care in prescription of any medication. Yeah, so I think that's what you're getting at. And that's right. It just needs to be something needs to be documented somewhere.
Just proper documentation, yeah.
Yeah, and it needs to be not buried in the notes. It needs to be a classification somewhere. Ryan, you can see us, can't you? What would you have referred him to nephrology clinic? In the 5th paragraph down there. Ryan's sick, so I'm not sure. Can you hear us, Ryan?
Yeah, I can hear you. Just thinking, I would potentially trial ceasing the naproxen and repeat it, because again, we only have 2 blood results, like 2 years apart. We don't sort of know what the trajectory is. So maybe trial stopping the naproxen and repeating the blood test in a month.
I agree. I think it's very important to keep it in-house as much as you can. Avoid referring. You've got the skills to manage this. As long as there's a good recall system and repeat system for follow-up, there's no reason why you have to. There's no real reason to refer him to a nephrology clinic unless there are other factors that we don't know about. So yeah, I mean, as you say, 3 years ago, prior to this, he may well have had an EGFR. It was only 59 anyway, so it hasn't changed that much. And if it recovers off the naproxen, I think a knee-jerk response to send him to nephrology is not really warranted. Maybe he's hypertensive and there are other factors, but yeah, that's good. No, that's excellent. So just on the second one, again, this one is an absolute disaster, as you'll see. So have spend a couple of minutes looking through that one, and then we'll go through again. Brad, you're first up. All good? Got a gist of what's going on there, and what's not going on. So I think Brad's left us, so that's all right. That's all good. We've got Mrs. O, 34-year-old mother of 3, visited a GP with a 2-month history of worsening vaginal discharge, which had recently become malodorous and in fact was blood-stained. Interestingly, in that comment, it says that the husband had been urging the patient to see her doctor, and then later on it comments that she hadn't really been attending for smears, etc., which raised some alarm bells anyway in the background here about maybe this lady is a poor attender, or she doesn't really engage particularly well with primary care. So that, again, we don't know much about the history. It's important to bear that in mind here. So looking at that first paragraph, Serena, welcome to the party. Just have a look at this paragraph here, the second paragraph here, GP Dr. A to the cursory history. Looking at that paragraph, what did you think about, when you got to the end of it, what do you think about that? It's all Dr. A.
Well, I think Dr. A should, I don't really sure if Dr. A is a male or female.
Yes.
But certainly he should investigate more into the discharge. Maybe before we hinted that we probably need SDI check or having a spectrum examination. Maybe investigate more into the fact it's a blood thin discharge and then any associated symptoms. Well, engage with the patient better in this case.
Yeah, I think what you just said at the end there, engage better with the patient. I get the feeling, I may be wrong, but there's a breakdown in communication, quite significant breakdown. The lady was obviously offended that she'd been told she might have an STI, and that would have put great reservations up about him wanting to attend an STI clinic, because she was probably, as it says, was offended. She hadn't been to a smear for 5 years, again suggesting that she probably has got those various issues around attending for that examination or even attending her GP. So that would need to be handled quite sensitively. And if it wasn't handled sensitively, you're on the back foot straight away in terms of doing anything. However, as you say, it's indefensible not to do a decent history and to do an examination. If it was Dr. A was a male and this is obviously a lady, and the lady refused to be examined by him, what would you suggest, Serena?
I would suggest if there is a female GP in the clinic, I will suggest maybe book her again with the female GP and then investigating more into that, if she is okay with that, or ask one of the nurse do a speculum examination if she thinks that's okay for her.
That's good. How would you frame that to her in terms of wording to her? How would you assume she's quite defensive, on the back foot, quite frightened and offish? How would you frame that to her to make her maybe want to do that?
Well, I will probably tell her that in this case, further investigation will be will reveal what's going on over here. And I would suggest maybe like do a speculum examination will have the greater benefit than just starting empirical treatment for her. And then maybe she will feel a bit more comfortable, even though like she did not attend to for a smear for over 5 years, maybe imply she doesn't really want a speculum exam at all.
Yes, that's right. Exactly. So just to suggest that, you know, obviously there could be something very significant going on here. You might be uncomfortable with a male doctor examining you, and I totally understand that. But I could get a female nurse practitioner, nurse or GP to undertake the examination, and we could take it from there if that's what you would like. How do you feel about that? And that's one way of doing it. It's all very touchy-feely, but that's probably what you want to be doing. That's right. So what you said that in a manner of words, you said exactly that. That's great. So going on to paragraph 2, she represented to another GP, Dr. B, several months later. And quite unbelievably, he did nothing further and encouraged her to make an appointment with the sexual health clinic. So I don't think we need to discuss that, because that's a bit of a no-brainer, really. You really wouldn't be doing that. A week later, Mrs. Zara re-attended the surgery with Dr. B. Saw the same doctor again, who then, even without further examination or further history, then provided empirical clotrimoxazole. What do you think about prescribing, Miguel, what do you think about prescribing clotrimoxazole in this situation?
Let me just have a read. I think it's quite broad spectrum.
Yep, that's one of the things that comes to mind.
To say the least. And I mean, just because without any, from what I'm reading so far, there hasn't really been any proper examination. So I don't get why they would give treatment without actually seeing what's down there, without any swabs or anything. But like, I mean, thrush shouldn't really have any bleeding.
Exactly right. That's all right. Go back to the first paragraph. Thrush does not present with bloodstained bleeding. It's very, very unusual. It's often not particularly malodorous. And there's usually other symptoms associated with thrush as well, which you can go into further. So the alarm bell should be ringing straight from the beginning here. This is very, very unlikely to be thrush. So if you're going to provide something empirical, and you shouldn't be without what you've just said, then you certainly wouldn't be using clotrimoxazole. As you say, this is a couple of weeks down the line, so things may have changed. So enter Dr. C, third GP. Funnily enough, the clotrimoxazole had failed to resolve her symptoms, and now she started to lose weight, urinary symptoms, bloody discharge had worsened, etc., etc. So Dr. C, in his or her wisdom, didn't do a history or exam and referred her to the sexual clinic again. So this is clearly going around in circles. And in the denouement of this whole process, as you can imagine, this was just, the ship was going to hit the fan at some point here. You've got this horrendoplasty of a case where you've got urosepsis, anemia, further investigation hospital showed obviously a CA cervix with local spread, possible PEs, and then metastatic spread to the lungs. Needless to say, she didn't do very well and died. And if you want to read the article in full, it will go through everything and how much they were sued for, etc. So they're not a good outcome. So I would have called that too many cooks without a recipe or utensils. Certainly wasn't too many cooks spoiling the broth. There was no recipe in the first place. Just I've put red there at the bottom, a bit of a highlighter there. Alarm bells should be ringing if you're the third practitioner to see a patient with the same problem. That's a very general rule. But if you're working in a big centre, particularly you guys that work in Carey or other IFHCs particularly, patients may do the rounds. And if you're the third doctor, even the second doctor at some point, and the patients come back with the same problems, alarm bells should be ringing and you should be being more proactive in trying to manage the situation or talking to the doctors, the patient's usual GP. I'm sure you'd all agree with that. So what I would tend to do, like in the first consultation, you can't hope to manage everything in the first consultation. So you need to, I would do a lot of the stuff in the first consult, maybe do the exam on the second consult, as long as I feel they're going to come back. I'd do the second consult maybe 4 days later. Now, by the end of the second consultation with any problem, you should have some investigations in front of you or be arranging further investigations to be discussed down the line at a third consult, maybe even a phone consult, to manage the problem. If it's drifting into a third consult in general and you're not getting anywhere, my rule of thumb is that you're out of your depth. You need to be talking to someone else to get some help. I'm sure that's probably something. Would you agree with that? Yep. So it's just, and that's the same even in hospitals, in A&E. If a person's been to ED with back pain, then they've gone to after hours with back pain, and they've come back to you as their usual doctor. Even though it's the first time with you, third presentation, same problem. You've got the alarm bell should be starting to ring. Okay, so those are 2 cases that jumped out at me, but I'd say there are heaps in there and well worth looking through. Maybe not before you go to sleep, but it's quite educational. So just a bit about continuity of care. It's the cornerstone of effective, safe, and enjoyable general practice. Definition of continuity of care, well, it speaks for itself really, but NZMJ in the journal in 2011, it's been defined as seeing the same healthcare provider over time and has been shown to be associated with positive health outcomes, high quality care, high patient satisfaction, and with lowering health costs. Continuity of care is a central tenet of the RNZ-CGP Aiming for Excellent document, which was published in 2016. In the Australian Journal of General Practice 2018, it commented that despite wide support for continuity of care, and we all do support it, and we say we support it, there's been a steady erosion of general practice continuity care over the past 30 years. So, Josh, why do you think there's been a steady erosion of general practice continuity of care over the past 30 years? Just to throw some ideas out there.
Modern world, people moving around a lot, changing locations.
Nomadic,
people change jobs all the time and end up all over the place.
Yep, that's one reason. Why else might have broken down?
Lack of resources.
Yes.
There's not enough GPs and they're full all the time.
Yes.
Or they're having to be placed everywhere, moved around and shifted.
So they'll go to, a person will go to whoever they can see, whenever they can see.
Yeah.
That's convenience, isn't it?
That's
right. That's one of the reasons. And also, over the last 30 years, obviously, there's been a growth in bigger centres, IFHCs, which certainly have their advantages, but it can also be a path of care because you're ending up with walking clinics and acute care, and everything's been tried to manage on site, which is great because it's one place, but the patient will often end up seeing 2 or 3 GPs for a certain problem, and if there's no handing over, problems can develop. And that's the same in smaller practices too, but maybe less so, as we'll see. Telehealth also has a part to play, good and bad. We'll come to that later on. So can it be studied? 2 articles I just dug out. It can be studied, and it's quite interesting. I don't want you to read all these. I'll try to bullet it in the interest of, sorry, do someone want to say something? No, you're good. In the interest of time, I've tried to bold things out here. So British Journal of General Practice in 2015, randomized controlled trials have been done, both positive for continuity of care. So it's not just something that's out there that we aspire to do. It has been studied and been shown to make a difference to patient outcomes. So they did a study there. There was 100 of them with a positive association and only 3, if that, with an adverse effect. And on the balance of probabilities, continuity of generalist care is beneficial to patients, and both patients and clinicians deserve to hear that message. In the BMJ in 2017, they actually got a measure of continuity of care. So it's called a care index score. Now, I'm assuming, I didn't read the whole article. This is more of an editorial summary. I'd say the care index score was 0.61. that to me suggests that it's defined as the proportion of contacts over that period with the most frequently seen general practitioner. So I imagine 61 would be 60% of the time they were seeing the same GP, and 40% of the time they were seeing someone else. Would you agree with that? Does that look about right? With practices with more doctors, the average score was 0.59 in large practices, and in smaller practices 0.7, which is what I sort of alluded to earlier on. The smaller practices tend to have better systems for continuity of care. Higher continuity of care was associated with fewer admissions for ambulatory care conditions. And in modelling, in terms of for the bean counters, modelling was done, and they found that if there was, they predicted that if there was an increase in the usual provider care of 0.2 for all patients, there would be a reduction in the number of admissions by 6.22%. I interpret that to mean it's gone from 0.61 to 0.81. So for your average patient, if they can be looked after 2 more times per 10 visits by their usual GP, there's a 6% reduction in admissions, which means they need to be, out of 10 visits to the GP, they need to be seeing their GP 8 times out of 10. If they're only seeing them 6 times out of 10, there's a significant onus on after hours, etc. Anyone disagree with that, or would that be what they thought without access to the full paper? That's what I've sort of considered. 6% may not sound much, but if you break that down by numbers and then by cost, and we all know how much it costs for a patient to be seen in A&E and then on to hospital, it's a significant amount. And you think about that money could be redistributed back into primary care or into other areas to enhance continuity of care, the figures will get even better. This is the last thing I would recommend you reading, even digging out. If you've got any interest in general practice whatsoever, I'd suggest getting this editorial out. It's very good. 2017. They alluded to a study where they've studied 230,000 patients and concluded that elderly patients who saw the same GP a greater proportion of time experienced fewer hospital admissions. Generally, continuity of primary care is associated with reduced rates at emergency departments. I like this line, I've underlined it. It's something that's probably not concluded enough. We hypothesise that seeing the same doctor builds trust and a sense of mutual responsibility between the patient and GPs, and it's a very tidy way of putting it. It's not just it's not about the patients just come back all the time. It's actually they build up a sense of trust in the practice, and likewise the GP takes a lot more ownership and trust in the patient and the system within which he or she is working. Professional pride, again, that alludes to the GP having more confidence in what he or she is doing and enjoying their job. It states here, a primary care system that is increasingly fragmented, in which neither patients nor doctors feel strongly connected to the local general practice, provides a setting for patients to choose to attend an emergency department instead. The last paragraph here talks about super practices that are emerging in the UK, which then sort of accentuates the threat to continuity of care. Now, got to qualify this. The super clinics that are popping up in the UK and have been popping up for the last 10 to 15 years are probably 4 or 5 years ahead of where we're at in New Zealand. And I think in New Zealand, we're taking a more circumspect review to polyclinics and big clinics and trying to make them better and better experience for patients. So I think we're probably doing better than the UK, but it's still a note to take from them. Is bigger better? It concluded that some patients value the new forms of access offered by the larger organisation, but others voiced concerns about losing the ongoing trusted relationship with their own general practitioner and their own practice. So what's coming through there is trust, trust, trust. And that's possibly what's being eroded as we head into the future. That's one of the factors. Research is needed to support the emerging super practices in finding ways to avoid losing continuity of care. Ellie, what do you think about those? Those 3 things there. What do you think about them? Were they useful? Were you aware they were out there to be read?
I wasn't aware of those articles, but I'm kind of familiar with the concepts that they covered. I guess it's quite interesting because the nature of the job of general practice has changed, and I guess your ability to provide care to the number of patients has probably decreased with all the in terms of managing all the behind the scenes and paperwork, and so it is quite an issue, I guess, still being able to deliver that continuity of care to so many people with so much workload, and how you overcome that.
Yeah, it is. You're exactly right. It's tricky. And I mean, average patient population size in a practice size probably 20 years ago was around about 2,000 per GP, maybe down to 1,600 in some. But now I think the average population size is down to, the average is down to about 1,200 to 1,400. That takes into consideration all the part-time workers that we have in general practice. So the population sizes have shrunk, as you've suggested, because I think there's a realization we just can't manage to an effective way that number of patients with all the follow-up and the safety nets and the care we have to take with our patients. Yeah, so like you, I wasn't aware there were studies out there, but it's always encouraging to find studies that just generally do support what we're thinking, and they have been done, because as we know, everyone's after evidence and back up our claims, back up our hunches, and this does sort of tend to back up the hunches. We have to have more balance, but we also need to be providing continuity of care somehow. So have any of you had the option of working in a bigger centre and a smaller centre at all? I suppose, have you any of you had experience working in a small and a big centre? No, it's probably your first GP run, so you probably haven't had a chance to do it much else, apart from maybe your own GP practices that you maybe go to. Okay, so this is the sort of a summary here of themes emerging. This is the last slide before we go on to the case that I want to present to you, run past you. How you going, Ryan? You still there?
Yeah, I'm still here.
Still alive?
Yeah.
Good. So advantages of continuity of care. This is basically a list that I've taken from the studies that I've looked at here. There's a generally greater patient satisfaction. Undoubtedly, there are practitioner preference and satisfaction. We all want to have continuity of care. We get much more out of it, so we need to be striving for it too. Lower all-cause mortality, fewer hospital admissions, ability to provide more preventative cares, effective preventive care, not just token, better compliance with medicines and treatment plans, improved outcomes, and decreased litigation. If you've got good continuity of care, good systems, you're probably not going to end up in the NPS journal. And again, I've just highlighted that continuity of care builds trust and a sense of mutual responsibility between the patients and the GPs. What about threats? So I think Josh alluded to it earlier on. What's happened in our current climate and the way we live and our lifestyles. There's this walk-in clinics are springing up, acute clinics are springing up, the bigger centres, polyclinics that aren't necessarily focused on continuity of care. That's why I put down path of least resistance. Why don't we just have 15 doctors lined up in cubicles, and you just roll in, you see a doctor, you get discharged, roll in, get discharged. It's very cost effective for the practice, but it's not cost effective. It's healthcare and for the nation's healthcare in the big picture. Some patients want to just let it mind who they see. Do you come across anyone at all? Miguel, have you come across anyone who really doesn't give a damn who they see? They just want to see a doctor?
Yeah, there's definitely been like quite a few patients that like doesn't even mind seeing me with that effect as long as they get what they want. So,
well, they get the non-steroidals.
Yeah, as long as they get their fix of something.
But, yeah, and what do you think about that?
I mean, like, I think that's fair enough. I think, like, I mean, I guess in terms of like the services I provide, like it kind of, it's just a bit more of an indirect service that they get, but it's still kind of, there's still consultant input there. So I think that actually makes it easier for us, I guess, like trainee doctors as well. And because I've had my few cases of patients that only just want to see the doctor that they're with, and that makes the consult very difficult in the sense that they don't want to be there, and you kind of just don't feel like being there either, but you kind of still have to help them out. So yeah, I mean,
they appreciate it. I mean, I imagine they greatly appreciate it because there's a doctor here who maybe has a little bit more time than the usual doctor and taking a bit more of an interest in them. But it's hard. I mean, and you presumably you safety net. You try and get them to come back to see the usual doctor, or come back to see you in a couple of weeks later. Yeah, okay. Telehealth's an interesting one, in the sense that yes, we all seem to be in favour of telehealth as the way forward. But as we know in the UK, you heard of this Dragon program, Dragon company, where you can basically just dial up anyone, and then to the phone there's someone there waiting to a video call from you. They don't know your history necessarily, but it's highly convenient. So what, Ryan, what would you think about that? What do you think about a system where you can just dial up a GP on the end of a video call in Singapore or London?
I think that for certain issues, sort of very routine issues, it'd probably be quite convenient. But for a lot of the more complex stuff, the fact that they don't know your past history is going to make it less useful. And if they even try to get that past history, that's really slowing things down. A lot of the times when I see patients, I'm spending a good 5 or 10 minutes going over things that their regular GP would already know.
And you've got, if you're doing something, if it's someone you haven't seen before, you've usually got access to their notes, haven't you?
Yeah,
which makes a difference. Yeah.
So if it's,
I imagine. Sorry, carry on. Yeah.
So I was just going to say, if it's I fell over and I sprained my wrist and I need an ACC form and maybe some painkillers, but I'm otherwise a reasonably fit and healthy person, then yeah, that's probably, as long as there's no risks of it being a break as opposed to a sprain, it probably would be okay to just see some random person who doesn't need to know extensive history. But for most things, it wouldn't speed things up at all.
Of course, you check their renal function before you prescribe the ibuprofen.
Yes, of course.
Of course you would. That's right. Yep. No, that's exactly right. And I imagine there's an over prescription of medications in these situations as well. I imagine there's a lot more antibiotic prescriptions blindly based on the history of possibly inappropriate drugs. So I think the cost of medicines would go up in that situation. But it's not ideal. But again, as you said, Josh, it's convenient. It's all people can get. They've got to wait 6 weeks to see their GP. They'll see anyone. If they perceive it to be a minor problem, they'll go and see whoever they can. So we need to address that somehow. Into the future, how do we secure continuity of care? These are some ideas that I've got really, but they're certainly not the panacea. It's obviously of growing importance. We need to strive to preserve and establish the trust between patient and practitioner, and that involves good history, good rapport, good patient skills, etc. It's ensure that they have a choice. I mean, some patients love going to the big places, and that's to be encouraged, and some others prefer the smaller practices. So we have to be able to provide a variety of options for patients. We don't want to go all one way or the other. Telehealth, the good, the bad, and the ugly. Telehealth's got a great place to play. It's got a great future as long as we use it judiciously and carefully, like I talked about a couple of weeks ago. Considering models such as something like the healthcare home, which I know Carey are involved in, and some of the other bigger places, some of the smaller practices are now starting to do it. A central tenet of that is continuity of care, and it's very, very good in terms of trying to keep the patient in your practice and avoiding referral to secondary care and doing as many procedures as you can on site. I think, Josh, you also said well-funded. We need to make sure we're well-funded and supported, and also any decentralisation of services from secondary care to primary care, which we're all generally happy to do, are funded, and when it's not dumped upon with unreasonable expectations on our services. It's also important, one other thing we haven't really talked about is to remain generalists and avoid the temptation to sometimes refer to alternative providers. So when you come out of your fully qualified doctor and you've done a few years in the hospital, you've had a lot of training. You're very, very highly qualified people, and you are generalists at that point. You've had experience in most aspects of medicine, and you should be able to manage most things. And in the future, we've got to be careful to make sure that there aren't sort of subclinics just pop up to deal with the gynae issues or deal with purely with the psych issues, particularly in primary care. It's easy just to flick people on, but in fact, we have got the skills to deal with it ourselves, and it's important we still try and hold on to doing that. Okay, so just to switch your brain on for the last 5 minutes, here comes my zebra, not my horse. So you're probably pretty hungry, so I'm pretty hungry, so let's get on with it. So this is a recent case, 81-year-old man. Now I must just claim, this is a patient who used to work in my old practice. My wife and I have recently moved to a smaller practice, and he was seen and managed initially by the older practice, and then came over to us because he wanted some answers. So 81-year-old man, he's married, alive and well, fit and well. He's alive, of course he's alive. And he was just on a omeprazole for GORD and Barrett's 2003. That's really about the only history you need to know about. In February, he presented to his old practice with some chest tightness and a mild tight feeling over the right side of his head, and he was started on amlodipine, presumably because they felt it was hypertension. His blood pressure was 160/90, so that was a reasonable first thing to do. 8th of April, he then presented to his old practice and he had a telephone consult under COVID. He was presenting right-sided headache on and off for a few months. And that day he had sudden worsening and associated diplopia. That's worsening of the headache and associated diplopia and reduced vision. GP arranged transfer to A&E, query TI, CVA. Josh, what are your differentials at this point? Given the fact that you know nothing, I've given you no information. What else? What are you thinking about this guy?
Migraines. Could be tension type headaches. He might have, I mean, at worst, something, a lesion developing in his brain.
Yep.
Yeah.
Okay. So migraine, is it usually unilateral?
It can be.
Yeah,
my understanding.
Usually is. And is it visual disturbance?
Yeah, usually there's some sort of aura.
Yeah, it can do. It's a short-lived visual. He was suggesting there was more long-term. It was more going on and off over a couple of hours with the headache as well. Tension headache, is that usually unilateral or bilateral?
Usually bilateral.
Yeah. Okay. So, and what do you think about the tentative diagnosis of TIA, CVA?
Reasonable based on the history, age, blood pressure.
And what would you have done in that situation under COVID? He's got right-sided headache on and off for a few months and a sudden change in vision. Would you have done the same thing?
A&E, yeah, full assessment.
Yep, that's what I would have done. It's exactly what I would have done. I mean, he's got to, you don't want to see him on site. The likelihood is you're going to refer him anyway. And it could be a whole gamut of things. So the most important thing is he needs imaging. Yep. So the differentials were on the right line, but you've also got to remember that some of them didn't quite fit with the history. But again, I haven't given you the whole history because I haven't got all the information because I wasn't consulting him at the time. So he went to A&E. He had a full workup, including the usual investigations and some bloods. CT showed moderate severe CV disease, which is probably appropriate for age. His headache diminished 2 out of 10, and he was discharged on a statin and aspirin with a differential of TIA, migraine, or tension. So basically what you just said there, Josh. Okay, so went home on aspirin and statin, and he was on the amlodipine as well for his blood pressure. On the 20th of April, we rang his practice complaining of ongoing headache, sore mouth, sore tongue. Eating is tiring, causes pain, he feels too tired to eat. He lost 4 kilograms because he couldn't eat. He demanded a face-to-face, nothing to find, referred to ENT to rule out oral cancer, given salt gargles. What do you think, Ellie? What are you thinking at this point?
I'm thinking GCA at this point.
And why are you thinking that?
The headache, the visual changes, and the jaw fatigue is pretty classic for arteritis. It's in the right age
Go
group.
to the top of the class. You're right. 8th of May. I think you sport it. You're not supposed to get that early. Mind you, I suppose you probably, I imagine you all would have got it by that point. You would have all got it, wouldn't you? You all knew, didn't you? I'll come back to that anyway. So basically, 8th of May, he didn't feel like he was getting bang for his buck, and he was feeling a little bit lost, and he wanted to see his old GP, so he joined my practice. We did a telephone consult, got the history, and basically I did some investigations based on that history, and it's all very easy in hindsight, and told him to come see me the next day. So of note, going back at the beginning in A&E, all they did was they did the usual suspects, but they didn't do a CRP, they didn't do an ESR. The CBC was completely normal, hemoglobin normal, platelets normal. And I got him back, and I saw him the day after I did the investigation, CRP 61, ESR 76, platelets 459, white cells up at 10, normal hemoglobin. So yeah, Ellie, your hunch is right. That's what I felt was going on. So I didn't even see the patient. I referred him directly to ED. Would anyone see him, or would you refer straight to ED? Grail, what would you do?
I mean, like, if I already know the blood test, and I guess, like, sorry, did you see him before, like, in terms of, like, examination? Or?
No, I haven't examined him yet. I've just gone on the history before. And again, it was sort of, it's COVID time. It was sort of still, do I need to see this patient?
I think, like, if I have quite a high suspicion of GCA, I probably would just send him through A&D, just because the risk of blindness is quite high, especially since he's been having the visual symptoms as well.
Exactly. I think it's perfectly justified. There's no point in coming to see me and then refer, because I'm going to do it anyway. There's a drawn out history. It's not sudden onset, suggesting that this needs to be worked out. And what's the thing that jumps out there in terms of that, the blood tests I did? In here. What's supporting the diagnosis?
So the CRP and ESR are raised, but the white cell count's normal. And after you've treated it, they've come down. And
yeah, that's right. And he's got weight gain because he's on steroids, and he's able to eat again. He had miraculous. He was getting jaw claudication. That's what struck me when he told me the history. Now maybe he didn't tell that to anyone else, and I was lucky. But he told me he was getting jaw claudication. So when he was eating, he was exhausted. He couldn't swallow properly. It was, and he was getting the headaches, and then he threw in the visual disturbance. I thought, hang on a minute, something must be going on here. So I was the fourth doctor had seen him, and I was lucky enough to have the benefit of retrospect, which is easy, hindsight. But this is the first case I've seen. Josh, do you know how common it is?
Not off the top of my head.
No, I didn't expect you to. I had to look it up too. There we go. This is a quick summary for you on one page. Just the highlight points here. Typical age of onset 70, rare under 50, more common in women. In the UK, it's 2.2 per 10,000 patient years. That's pretty uncommon. And the reason why we sort of hammered it as a differential is the consequences of a false diagnosis or missing it. So anyone presenting with unilateral headache, usually tender scalp, jaw claudication, visual disturbances, it's this until proven otherwise, even though it's rare as hen's teeth. Some interesting things here. Headache's not universal. 50% of patients with GCA exhibit PMR, 20% of PMR exhibit GCA. So those patients with PMR, 20% of them will have symptoms or suggestive of GCA. I'll just throw that in there. That's the sort of the criteria, and you can diagnose it really over the phone or in your room based on 3 of those 5 criteria. And the process is you refer to hospital. They should have a biopsy done before steroids are started, but inevitably it's always 3 days later, and by then the steroids have muffled the sign anyway, which is what happened with this guy. He got an equivocal biopsy result. And the ESR CRP thing, we used to do lots of ESRs about 20 years ago, and then there's a switch to CRP because ESR was never used, but there are certain circumstances where an ESR is very useful, and the use of it in a targeted manner is perfectly reasonable. So it's useful in myeloma, it's useful in giant cell arteritis, and polymyalgia to a degree. But polymyalgia, usually the CRP goes up nicely irrespective of the ESR. The reason why it's good is that obviously 4% of patients with GCA have a normal ESR. So if you've got an abnormal ESR, and you've got these symptoms, again, it raises the index of suspicion hugely. And temporal artery biopsy is equivocal in this case. In the UK, they're looking at ultrasounds of the temporal arteries instead of the biopsies, which might give some more information rather than that time-consuming biopsy, which always happens way too late anyway. So, and Ryan, how long do you think this guy's going to be on steroids for?
I don't know. I'm not sure.
It's a long. They start 60 milligrams, they whack them hard, and they come down very, very slowly. So he'll probably be on them for 6 to 9 months. High rate of relapse. So the things you're usually going to be looking at, of course, some of them steroids, diabetes, developing diabetes, osteoporosis, weight gain, hypertension, etc. So that opens up a whole new sort of area of management he's going to have and lots of follow-up, etc. And that's where continuity of care is quite useful too. Any questions about that at all? Anyone seen a case of GCA? No, that's the first one I've seen. And when we talk about next week, next Thursday, we're doing a sort of a pre-exam, bit of a warm-up thing, some questions they might ask you. One of the things they'll ask you is headache, because sometimes they throw a headache at you and they want to know what the differentials are, and this is one of the ones you'll have to say, even though it's very unlikely to be that. So again, it's just worth considering.